I'd like to invite Dr. Fenwick to the stage and open up for questions and answers.
First, I would like to thank all of you because I think this is a very important part of our meeting. When each one of you share your own experiences in the clinical practice and what you're doing. But I would like to ask Dr. Christoph Kind. He shared with me one particular case that he followed, and is very touching and an example of what we can do when a patient has no more hope for as a clinical treatment.
Thanks very much. I'll just make sure that I've got the question. So what do we do if a patient becomes absolutely hopeless and is totally swallowed up in their own feelings of despair? Yes, the patient is in pre-transition. They still haven't, in fact, given up a lot of attachments to things, and they're still hoping for things to come. And it's really talking to them, supporting them, and pointing out that there is, in fact, quite a bit to come as they go through transition and then into post-transition. And as you get closer to the end of life, they will start getting experiences which can help them. Now, it used to be thought that these experiences were very rare, but our data suggests that they were common in about 50% of patients, but Rentz's study in Switzerland suggests that it goes up as high as almost 90%. So most patients will get a end-of-life experience of some sort. I think one of the most important points was told to me by a palliative care nurse in Canada. And she said that she quite often had patients who were alone and who were desperately fearful of dying alone. And she said, well, there is the possibility that you can get help. Tell me, who amongst your relatives did you like, and who was enormously important to you? They'll usually mention somebody. And so she said, what's the person's name? And the patient said, Mary. And so as the patient got closer to the end, she said, is Mary here yet? And the patient said, yes. And so she said, okay, we'll go with Mary then. And this was the most wonderful linking of the person to the patient, and she could then go into post-transition very easily. So I think it's recognizing where the patient is and then giving them what they require.
Thank you.
Thank you. I'll pass the same question to Dr. Christoph Kind.
Sure. Well, I think first of all, the role of the clinician is to not take hope away, which we can do in the way we deliver bad news or try to convince the patient of the reality of their situation. I think what gives hope is your relationship and education, talking through. Some people want to know what's going to happen. But even before that kind of transition, there's a lot of questions for themselves to come to terms with still the possibility of cure, and that transition for people is very different from individual to individual, and it's just honoring who they are and being there in whatever capacity you can and choose to be, and seeing what kind of support can be around the particular individual so that they do feel safe and they begin to understand that who they are is beyond the limitations of their physical body or how they feel. So there are a lot of educational things, and just, again, the sabbaitaio, which is really profound to me, is something that gives hope. And it doesn't have to be hope in a cure. It's a hope that things are going to be okay. And I don't know what happens after death. I mean, I have thoughts, I have some beliefs, but that doesn't really matter. I think we all at some point come to some understanding that maybe our spirit, our being, is somewhat eternal. And so that's all that really matters. We can have many interpretations of faith or otherwise, and it's just honoring who a particular individual is. And like I said, there is always something you can do to optimize a particular situation. So for me, there's never nothing to do. And that may be just holding somebody's hand and loving them. It may be a particular botanical medicine like echinacea for pain, or whatever. So it's maybe just pausing a little bit and not trying to fix something, but providing care step by step as the situation warrants, which it will change maybe in 5 minutes again. So I hope that sort of answers some of the question.
Next question.
Yes, I've been working with patients when they die in somewhat of a mediumship role, and bringing in loved ones and working with that transition, that crossing over. So I'm wondering what direct experience any of you have had in working with patients when they die, in using mediums or yourself.
Anyone wants to? You want Dr. Fenwick?
Can you give me the question again?
If there is any, if I understand well, if there is any function for a medium to be a bedside and when the person is passing?
Yes. That's a very good question. I think a lot comes back to the question of education and preparation. In our culture at the moment, death and life are seen as quite different things. Death is not part of life. And if we change our cultural attitude, then kids at school will be taught about death and what it means. And if you think about children at school, they come across death frequently. I mean, their guinea pig dies and they have to come to terms with it, or their cat. So they will have a concept of what death means. Now, can mediums help? Yes, it depends entirely on the belief structure of the individual. If they want a medium, certainly. But don't forget, the patient isn't there in isolation. There's also the family too. So again, it's going to be a question of whether or not the family want a medium. But I would say there's a definite place in that for those people who feel they want it or need it.
Kirsten, you wanted to answer that?
I think there definitely is a place for it, if not in some way, shape, or form. Perhaps not so ostensibly, perhaps not in the ways in which you might have in mind. But what I have in my mind is that I've had a handful of situations where I was the only person at the bedside, aside from maybe one or two other clinicians, at the time of death, whether similar to Dr. Kind's experience where family had abandoned them for a variety of reasons, and we were the only ones there to walk them through that process. And more times than not, I have felt the sensation of, my guide or the good spirits there, and just sort of passing along, positive message. And I had more than times than I can even think, I've had patients at their time of death where they were saying, oh, well, I'm scared, and they were saying, I'm going to die. I had a patient that he had gastric cancer, and he also had a slew of other comorbidities, and he kept saying for 2 days while in the ICU, and he was literally just bleeding all the time. We couldn't put enough blood back in him. He just kept bleeding and bleeding from his rectum. And he kept saying, I know I'm going to die. And he did die 2 days later. But I remember distinctly the day that he died. It was probably about an hour before when he looked at me in his state, and he said, and I held his hand, and he said, I'm going to die. I'm going to die. I said, that's okay. I'm here. At least you're not going to die alone. And it seemed like something changed in him, and I felt something change in the air, and I felt that was something that someone had me say to him. And about an hour later, he just passed. And mind you, for those 2 days, because he also had an underlying psychosis, he just kept repeating the same thing over and over again, over and over again. I'm going to die, I'm going to die, I know I'm going to die, I'm going to... So imagine the scene, and now just peace. So I think that we are led, whether we believe in spirituality or not, we are all mediums to some degree or not, good or bad sometimes. But I think if we have an earnest desire to be good and to share goodness with our patients, that'll definitely come through. That's my experience. Thank you.
Next question.
First, I would like to thank you all so very much, and to the other speakers for the wonderful lecture that was brought to us here this weekend. And I have a question for you all maybe, but especially for Dr. Peter Fenwick. Was mentioned here about near-death experience, that a lot of your patients see a tunnel of light. I'm curious to know if by any chance some of your patients see the tunnel of darkness. And also they asked me to repeat my question in Portuguese because our translator just left. And, em primeiro lugar, eu agradeci a todos, os nossos palestrantes, e a pergunta que eu fiz foi que muitos palestrantes mencionaram o túnel de luz, que muitos dos seus pacientes sempre viram túnel de luz. E eu gostaria de saber se alguma vez eles viram algum túnel de escuridão ou de trevas. Thank you.
Okay, let me deal with the question of the tunnel, first of all, because it was really interesting. There was a time when I was enormously interested in the tunnel, and so I was looking at the experiences we've got. The bulk of the experiences that I studied came after we did a television broadcast in the UK, and that was in '87, called Glimpses of Death, and you can still actually see it on YouTube. And following that, we got 2,000 letters. People used to write letters in those days. And if you knew that was your data sample, how many women and how many men would you expect? Well, we got 75% women. Do you think that's due to the fact that they're much more spiritual than men are? No, of course not. They write letters much more easily than men do. So that was our data sample. We took 500 of those and sent out a questionnaire to these people, and we got 412 replies. So these were people who had had really comprehensive near-death experiences. Now, in that, it became very, very clear that there is no stereotype tunnel. Some people would see something like a washing machine hose, and they would go down that. Other people would see that there was a blackness through which they were floating towards the light. Other people would feel that it was a sort of cosmic experience, and they were going into the universe and turning around and going towards the light. And so the tunnel and what you see, I think, is very dependent on you. And however much we tried, we couldn't find anything which would tell us exactly what sort of tunnel you were going to have. And of course, not everybody has it. I think it was, if I remember the figure correctly, it was around 30% in our sample that actually had a well-formed tunnel. Otherwise, people just arrived in various places. But remember that it's very culturally determined. And the Japanese, they don't have a tunnel, or tend not to. They cross a river, and there's a boatman that takes them across into a dark forest on the other side. So there is a cultural component to it as well.
Thank you. Anybody else would like to address this issue? All right, so we move to the next question.
As we discuss these kinds of transitions from life into death, I think about people who are victims in war, where they don't have the luxury of this meditating as their life progresses into death. And I was wondering if there have been reports, let's say, of people maybe in Iraq or Syria who saw family members shot and killed and then got hit themselves and went through an NDE and came out, or whether there were soldiers who had killed people and then they went through an NDE when they themselves got killed, got shot, and you know, because I heard from you in earlier things, Peter, or possibly from Pim, I can't remember, about you feel the pain that you've created to other people. So I'm wondering about situations in wartime, in places of extreme trauma, and how people resolve their near-death experiences in those situations.
This also can imply for any acute trauma besides war, correct?
Yeah, but I'm thinking more of the killing and losing family members right in front of your face, and you know, this
Okay.
kind of thing.
I think that's a question for you again, Dr. Fenwick.
Yeah, sorry about this. In fact, I'm the wrong person to ask that question to because
Okay. Well,
I haven't.
whoever.
I'll pass it on to the others because I haven't studied it. But the people who have studied it say that yes, they do go through near-death experiences, and in people who are in war zones, they have a lot of trauma in their psychology, and so of course when they come back, it's the expression of this trauma into their personality. But their near-death experiences, from what I've gathered, but I'll ask the others, are very much the same as the near-death experiences that we all have.
Repetindo a pergunta em português, a questão é qual a experiência que alguém do painel possa ter em morte por traumas agudos, principalmente em guerra, se existe alguma transição, se algum de vocês notaram em relação aos seus pacientes. I think
Okay.
I haven't read any reports about war, but I think from what we have read and in my personal experience by having my son write down how his transition was, it was a period in which he was taken away to rest. There was never a mention of any transition while he was alive after an injury, or if there was anything happening doing CPR or whenever the physicians were attending to him. But that period lasted quite some time, in which he was very confused, unaware of where he was, sometimes with periods of awareness, until gradually, with support of his of medical and nursing staff, he began to become more aware of what had happened to him. But it was very sudden, and I think from what we read, it takes some time until the individual realizes that he or she is dead. And it depends a lot on their previous beliefs and religion and so on. I don't know if that answers it, but it sounds like you don't really have time to go through the stages that Dr. Fenwick.
Your son didn't die in wartime, did he? Or?
No,
Okay.
but I'm assuming that the trauma, the injury is very
Right.
similar,
Okay.
or any acute trauma.
All right. Thank you.
I will pose the question in Portuguese first, as Dr. Lucchetti, and then I will say in English again, so all of the speakers can address as well, if possible. The question a pergunta que eu tenho, desculpa, A pergunta que eu tenho é justamente se você pode identificar ou trazer a necessidade ou as necessidades de uma pessoa que está nos momentos finais de sua vida. E como nós poderíamos ser mais eficazes como familiares, amigos, em ajudar nesse momento. So the question is basically about the necessity or the necessities of family members, friends that are dying, and how we, as those around, can identify these needs of an individual, the need of an individual.
Dr. Lucchetti, speak slowly because I'm going to translate and I'm not a translator.
Ok. Ok. Como outros colegas já disseram aqui no painel,
How some of our colleagues have said,
a família tem a necessidade, e o paciente também,
the family has the need and the patient also,
acima de tudo, de ser acolhidos
that they're being welcomed
em suas necessidades, seja na dor, na dor espiritual, como a Marcia colocou na palestra dela, a dor total,
and supported in their pain and grieving. And as it was mentioned before, in the total pain.
E eu acho que o principal para o paciente e o que o profissional de saúde, nesse momento, tem que passar tanto para o paciente quanto para a família,
And the most important for the patient and for the health professional approach for the patient and to the family
é que ele está do lado. Ele está...
is that he or she is there with them.
que ele está pronto para acompanhar e dividir aquele momento com a família, com o paciente e trazer o maior conforto possível.
The professional is there to share those moments with the patient and the family and to bring the most comfort to them.
Como foi colocado aqui, às vezes o silêncio, só você estar do lado já é o suficiente.
As it was mentioned
Você não
before
está sozinho.
by Dr. Kind,
Yes.
just sometimes being there or holding hands is enough. Thank you. Next question.
I'll just make another little comment, which, and as we've sort of talked about, there's healing in the family as well as with the individual, and as certainly as caregivers or as guides or as friends, one can help educate the family, because when there's peace in the family, when there's peace with the individual, then things are smooth and there's no struggle, there's no pain. I'm thinking particularly in oncology when there is severe metastatic disease or otherwise, there can be a lot of pain. Generally, those who have found more peace have much, much less pain and require less medication, and they tend to be more conscious as they die. So family is important, and it is important to facilitate that kind of peace and healing within the whole group. And I encourage family members to talk to their loved one, even if they're full of morphine or otherwise, because it's the spirit in you and the spirit in the individual that can understand and can communicate. And so even when someone is not responsive, and I'm sure you know this, as a clinician, I talk to the individual, explain what you're doing. You don't need a response. There's communication that happens beyond your words that is always there, and we're just not always paying attention to it when we're talking with someone in front of you. But anyway, I think that answers it a little bit. I will keep talking otherwise.
Okay. Dr. Salgado wants to comment on that as well.
Eu gostaria de falar pouquinho sobre isso,
I would like to speak a little bit on that regard,
porque acompanhei recentemente caso em família
because I have followed a family case
de uma doença devastadora. Em 11 meses, a pessoa partiu.
of a devastating disease in which the person passed away in 11 months.
Bem como uma outra amiga muito próxima, que ficou 5 anos com câncer também, muito difícil.
As well as another friend, very close friend, who had cancer for 5 years, a very difficult case.
E o que a gente vê é que o olhar do profissional que cuida do paciente,
That the way the professional looks at the patient, his or her eyes,
mas não só isso, toda a equipe, como o hospital no qual ela está recebendo tratamento, faz toda a diferença.
and also all the team of the hospital where the patient is, they make the whole difference.
No primeiro caso, as duas pessoas têm crença, são espíritas, tinham crença na vida após a morte.
In the two cases, both individuals were spiritists, so they had beliefs of life after life.
E, nesse primeiro caso, nós transferimos de um hospital para outro que tinha uma condição muito melhor de atendimento.
On the first case, the patient was transferred to a new hospital that had much better means of supporting.
E o suporte da enfermagem, no sentido de respeitabilidade, de presença, de auxílio, foi fundamental.
And the support from the nursing staff in terms of their presence, respectability, was fundamental.
Havia uma enfermeira que à noite vinha aplicar reiki.
There was a nurse that on evenings would come and apply Reiki.
E toda a enfermagem ficou muito amiga da paciente naqueles 37 dias.
So they developed a significant friendship with the patient in those 30 days.
O apoio da família, a presença, digamos, muito mais até dos amigos do que da família ali, com a oração, o evangelho, foi de grande auxílio.
The presence of not only the family, but the close friends with frequent prayer and support was also of great influence.
E no fim, a enferma realmente se entregou, sabia que não ia mais ter chance de sobrevida.
At the end, the person realized that she was about to pass away.
No outro caso, a paciente ficou num hospital muito frio, vamos dizer assim.
On the second case, the person was in a hospital that was very cold in a sense of not as empathetic or supportive.
E embora o conhecimento espiritual dela e do próprio esposo e tudo mais, ela não queria deixar a sua existência terrena.
And despite the fact that she believed in life after life and her husband and family, she really did not want to live or leave this life in earth.
Foi um processo de final de vida muito difícil, muito sofrido.
It was a very difficult process of end of life with a lot of suffering.
Cada caso é um caso, mas o que eu queria deixar aqui como mensagem
Every case is a case, but what I would like to leave here as a message
é que o médico precisa sair da materialidade em que ele se encontra.
is that the physician must leave the materialism where he stays.
Porque o atendimento que um paciente recebe de um médico com visão espiritual é totalmente diferente de um médico com visão materialista.
Because the care that a patient will receive from a doctor with spiritual training and beliefs is completely different than the ones that do not have those beliefs.
A presença, a compaixão e a solidariedade naquele que tem a certeza de que ali está um ser humano quanto ele é totalmente distinta.
The reinforcement, the support, the compassion, the empathy, and the way to look at and the fraternity that you look at the soul like him or herself makes very much of a difference.
É um aprendizado que o médico tem que fazer, porque embora às vezes ele tenha a crença espiritual, ele não sabe fazer esse trabalho.
It is a training that the physician needs to undergo, because even when he or she have the beliefs on a particular spiritual doctrine, he may not know how to apply that in practice.
E finalizando, realmente essa vivência do amor que o médico tem que conquistar em relação ao seu paciente, a todos que cruzam sua existência, quando ele possui essa vontade de auxiliar o seu semelhante.
And that, to finalize, this way of loving the patient and passing that to the patient is what's necessary to help those that are at end of life process. Thank you. The next question?
Okay, Dr. Kind, you said that you believe in something else after death. How do you manage when you receive some materialist patient? How do you talk with her or him because of his or her beliefs? And Dr. Salgado, in this case, you said in the hospital you have the prayer when you have the patient too. What do you do in your case? You have a materialist patient.
Okay. I will tell you the story of Mario, who passed away a month ago. He was the father of one of my receptionists. A year ago, he collapsed in my office with a sudden cardiac event and was resuscitated by my colleague and myself. He just happened to be in my office visiting a friend who was getting some treatment, and I was very curious about whether he had experienced a near-death experience. We had worked on him for about 18 minutes before he revived and had no obvious deficit as a result. He didn't experience anything. He was had a very simple view of life and just, this is it, and once I'm dead, I'm dead. And it's not my role to convert somebody to a way of thinking. But I can love this man and I can care for him. And so a month ago, well, he had a very rare skin cancer as well, Merkel cell, which continued to involve his internal organs. And he became very weak and was dying. And on his last day, I visited the family, and the family happened to be all there, and his breathing was changing. It was on a long weekend. He was going to need some other pain medication because it wasn't really working. He was a bit restless. And while I was discussing with his wife the options of, well, if you feel you can't deal with this, we will need to have him transported to the hospital. They didn't want that either. There were no doctors that were available over the holiday. And while we were talking, we imagined that he heard us talking, because then he became, his breathing completely changed to the last moments of death. And he passed away very peacefully with his 4 daughters and his wife there. They were just encouraging him, loving him, not hanging on to him, not saying, please don't die, just, it was, so it's not up to me but I can provide an environment which, and support an environment which allows for spiritual understanding and spiritual growth for whatever his journey was and is. And also then with the family, and having some resolution with the family that they were there, that they, you know, as I explained to them what was happening, then they could deal with that.
I did not understand the question to Dr. Salgado.
The same question, just how do you deal with a patient who has no spiritual But-
Doutor
or
Salgado,
Yeah.
como se lidar com uma pessoa que não tem nenhuma crença espiritual?
Bom, eu venho do Brasil. É
I come
difícil
from
no
Brazil.
Brasil nós encontrarmos pessoas que não têm praticamente crença religiosa.
It's very
Alguma
difficult in
coisa
Brazil.
tem.
It's very difficult in Brazil to find anybody that doesn't have some kind of belief or religious belief.
Eu trabalhei muitos anos na enfermaria de tuberculose.
I worked for many years at the infirmary for tuberculosis,
cujo nível socioeconômico é bem baixo,
which socioeconomic level was very low.
alcoólatras, às vezes ex-presidiários.
Ex-convicts, alcoholics.
Mesmo, às vezes, esses pacientes eles não têm alcance para entender o que é a própria espiritualidade.
And many of those patients don't have the reach to understand what is their own spirituality.
O que eu sempre fiz foi tentar ganhar a confiança,
What I always try to do is to try to gain their trust.
porque quando ele percebe que você não está dando uma receita para a doença, mas que você está interessado na pessoa dele enquanto enfermo,
Because when he understands that you're not giving a prescription of a medication, but you're interested in their individual, the
que você
person,
deseja o seu bem como um ser total,
that you wish their well-being as a total human being,
se estabelece uma ponte entre você e aquele paciente.
you build a bridge between you and that patient.
Então, você consegue, aos poucos, falar de uma força superior, de um Deus, de alguma coisa além. É um processo de trabalho com aquele paciente.
So little by little, then you can begin to introduce concepts of a superior, higher force, or God, etc. It's a process that it builds up.
Eu estou no ambulatório, não estou mais na enfermaria.
I'm working with outpatients, not with inpatients.
E eu trabalho com cessação de tabagismo.
And I work with smoking cessation.
Mas eu atendo sozinho, eu não tenho um grupo de apoio com psicóloga e assistente social.
But I see them alone. I don't have a support group such as social workers or psychologists.
E eu consigo os mesmos índices de cessação do tabagismo do que a equipe que tem o suporte.
And my outcomes are exactly the same as the team that has all support.
Porque eu faço o doente se ver enquanto ser espiritual naqueles poucos minutos de conversa.
So in those few minutes of conversation I have with them, I try to make them see themselves as spiritual beings.
É muito particular. Para cada paciente, você vai encontrar um caminho de acordo com a linguagem dele.
It's very individual. For every single patient, you're going to find their own ways, their own paths. We have a last question.
Could I just make
I'm sorry.
a comment on that? We're touching on an enormously important area. When we were going around the hospices in England, we found that there was a huge divide between the nursing staff and the medical staff. It wasn't uncommon for us to go into the hospice and find that the medical staff denied that there was any such things as end-of-life experiences. And they had a very mechanical view of what death was about. And this, of course, then led to difficulties in the prescription of medication. Do you give them drugs like midazolam and remove their consciousness? Or do you so sedate them that they spend their time asleep? Whereas many of the families wanted the people who were dying, their relatives, to be awake and to die quite naturally without this level of medication. So that was one point. The second point was that I remember there were 2 hospices I went to, and I asked if we could, if I could give a talk there to the hospice about the phenomena of death. And the physicians were very resistant, but they were resistant because they didn't think these things ever happened in their hospice. I think they saw it as a sort of failure that people should be experiencing the process of coming to terms with death. And so there was one hospice where I gave the lecture, and as we went in, the physician said, "You know, nobody in here will know what you're talking about." And when I started to describe the process of dying and what was involved in it, the nurse said, "Yeah, we had a patient like that. We had a patient like that. We had a patient like that." And it was absolutely amazing. The other hospice that I went into, we did the study in that hospice. So in fact, we've talked to the patients, we've talked to the nursing staff, we've talked to everybody about end-of-life experiences. But the director, when I gave the talk finally, and the feedback on the hospice to them said, "Are you sure you're talking about the right hospice?" So there is this great gap between the medical staff and the nursing staff who understand. And so I think it's enormously important that we do what the nursing staff and most of the other staff said in the survey that we did. They want more training. They need, in fact, to understand what the actual process of dying is. We've heard some lovely descriptions here of the kind of care which we should be giving to all our dying patients. But it's better than it was, so it's coming on.
Thank you. Before I get the last question, I received a question to clarify who Jan Stevenson was and the name of the article that Dr. K provided to the patient. Jan Stevenson, he passed away a few years ago. He was the chairman of the Department of Psychiatry at University of Virginia for many years. He built the most impressive case reports for reincarnation. I happen to have his books, and each one of them is about 3,000 to 4,000 pages, describing meticulously and scientifically corrected all of these cases. And the article in the Explorer magazine, which is a journal that is edited by Larry Dossey, and this article is written by Larry Dossey, is Birthmarks as Proof of Reincarnation. So if you look up at the Explorer, you will find this. It's a beautiful article. It's summarizing those thousands of pages of cases that you are welcome to look, because they're beautiful cases, and the scientific method that Dr. Stevenson used was impeccable. Now, the last question.
I've become aware that in palliative care and in dying situations in hospitals, and indeed even with my own mother who put out a do not resuscitate order, that the use of morphine and increasing levels of morphine to control pain and air hunger, as it's put, or Valium to control death anxiety, which my mother also received, is what I'm wondering is how conscious at dying can you have, and can you have these extraordinary experiences that you, Peter, talked about with increasing levels of morphine and Valium and fentanyl, if it does it? Or
I think it's an excellent question. I'm going to translate into Portuguese. It's just a matter of asking to achieve those transitional stages that Dr. Fenwick mentioned. Patients sometimes are... Huh? Oh, sorry about that. I'm sorry. Desculpa. You got confused, almost 5 o'clock. So, para deixar os pacientes passarem pelos estágios que o Dr. Fenwick mencionou, alguns pacientes são, o que a gente chama aqui, carregados com morfina. Qual a utilização de drogas para poder se manter os pacientes de um certo nível, ainda podendo passar por esses estágios enquanto conscientes? So who will answer that question first? Quem responderia antes? Go ahead.
I have an opinion, which doesn't mean it's correct. I do think morphine interferes, but it's also about the situation, and the dying process is equally important to the individual as the family. And so there has to be some balancing of that. And if there's a good preparation beforehand, if you have that opportunity, then the need for morphine becomes much less. Certainly with some of the more recent inclusion of cannabis-type medications, there can be also some benefit with pain that doesn't require morphine. But again, that science is still very, very early and a bit unpredictable. So I think every situation is a little bit different. And ultimately, I think one can trust that the walk is the walk. If we are acting with integrity and with love and honoring an individual with dignity and support, then we've done what we can do. And it's not completely up to us as far as, again, it's not up to us what the outcome is. It's can we be spiritual? Can we be loving and honoring a fellow human? And then, I mean, that's the nature of life.
Thank you.
Anybody else?
Just to piggyback off what Dr. Kind was saying, my experience with patients that were on palliative care or end-of-life care, there is no substitute. As Dr. Kind was saying, there are some newer medications that are still, being researched, but I think at the stage what we're at, every situation is so unique, every case is so unique. My, again, opinion, and take it for what it's worth, but I have seen hospice nurses, colleagues, friends of mine, who have certain beliefs about pushing morphine. So I think when Dr. Fenwick was talking about the need for re-education in the hospice and palliative care arena is huge for education, and not just in a necessarily far-reaching spiritual sense, or religious sense rather, but just more along the lines of what Dr. Fenwick was sharing, this whole process and what Kubler-Ross had shared so many years ago. I think it's still so true, is that when you have a dying patient, it's everyone that's involved, especially the family, to be there to experience that. And yes, there are really difficult situations. I actually had a patient's stepdaughter, the patient was on a morphine drip, and the stepdaughter came out to the nurse's station and said to me, how long is this process going to take, referring to her stepfather's death? And I was kind of floored and said, what do you mean? I thought maybe she meant something else, like my shift. And she said, no, him dying, my father, my stepdad, how long would that take? And I was like, well, I couldn't tell you. I don't have that ability to tell you when it's. She said, well, can you give him some more medication to speed it along? And I said, no, I will not do that. Your stepfather is perfectly comfortable. He's not moaning, and I just bathed him, and he's good. So we can see the family also has their own anxieties about death. So it's all about our own personal experience, how we're looking at death, how we're dealing with it. I'm going to throw out some Spiritist literature at you because I think it's so interesting to reflect upon. The spirit guide of a medium, Givaldo Franco, Joanna DeAndres wrote a book called Happy Life, and in this little book of messages, she says that we should think about death every day, not in a morbid sense, but in a way that it's natural to us. It's not like, oh my gosh, I'm going to die, but one day I will die. And so your emotions, so you can adapt to that. And I think that the other clinicians here also shared stories about people that even are deeply religious, that are Spiritists or Buddhists, and when they confront death for themselves, sometimes they don't have the expected reaction you would think. So it's such a personal experience. I think that overall, as Dr. Fenwick said, we need more education for ourselves and as a community.
One of my experience is that although there have been some significant improvements with hospice care, still the hospice care in most hospitals in the United States is really not very well done. And in many instances, drugs are provided so that there is less human contact. And instead of providing morphine for anxiety, as you mentioned, you could have held the patient's hand and said some supportive words as a first line of care instead of going through the drug. So that's very common, unfortunately, and that's why everyone in the panel is in agreement that we need more training for that stage. Anybody else?
Thank you.
Okay, I'll thank you very much for your presence, and now we're going to be doing the closing comments.
Thank you, everyone, for these lovely discussions, all the doctors, everyone. We want to remind everyone to make sure that you return your translation devices if you haven't done so. I know some of them were collected and were returned already. Also, to make sure that we fill out our surveys, front and back, and return them before we leave. I know all of us already are wanting to meet again, but guess what? We have to wait 2 years. It takes a lot of work. The workers as well, and the speakers, make sure you return your name tags to the staff as well. In the name of the SMA, we want to thank all the work that was done for each person who contributed, who came here, worked both days, yesterday and today, all the speakers as well, all the doctors that came here, going through the analysis of some of these, all of the individuals who came here does. It's amazing. It's a lot of work. And we also would like to thank the people who work with them, right? And all the information that we brought here. And we ask everyone that we multiply this, that we share this. We also wanted to thank those who follow us on the web, through the work of those, actually, Eduardo, Daniel, who brought this to the web as well, those individuals following us. Each one of us here, each participant, guess what? As we said already, we made a choice to be here to do something different with our Saturday, with our Sunday. And we want to thank those individuals again, because at the end of the day, as we learned here, we are the most important asset that we have for one another. So we want to leave you with that. We want to leave with one another this message of togetherness, of being helpful, being grateful for what we have, for the time that we are spending here, and some of the examples that we saw here, and the beyond as well. Years ago, if we were to ask Leo, and perhaps I'm saying this on speaking for myself, but many of you, as Kirsten have said, if we were to walk in this room today, we would think that we were having a very morbid conversation, right? Talking about death and going to the other side, dying, all this process that perhaps it brings a lot of tension to some of us and difficulties to some of us, but we're enlightening ourselves so we can actually deal better with it. On this note, before we pray together, before we can leave, I want to read a passage from the letters, Paul's letter to the Corinthians, talking about love. And we learn that this, with some scholars, that when Paul was talking about love here, he was talking about charity, which is love in action. The way of love. If I speak in the tongues of men and of angels, but have no love, I am a noisy gong or a clanging cymbal. And if I have prophetic powers and understand all mysteries and all knowledge, and if I have all faith so as to remove mountains, but no love, I am nothing. If I give away all I have, and if I deliver up my body to be burned, but have no love, I gain nothing. Love is patient and kind. Love does not envy or boast. It is not arrogant or rude. It does not insist on its own way. It is not irritable or resentful. It does not rejoice at wrongdoing, but rejoices with the truth. Love bears all things, believes all things, hopes all things, endures all things. Love never ends. On this note, we would like to invite everyone, if you wish to close your eyes, find a comfortable position so we can pray together. We would like to thank our dear Mother, Father, God, for the opportunity that we had to come to this beautiful event after the hard working of many people, many researchers, many years of sacrifice to this amazing moment, meeting new people, enriching ourselves, understanding who we are in the sense of better looking where we came from, what we're doing here, and where we're going. Tonight, dear Lord, we ask for your blessings, for your guidance, that each one of us can multiply these teachings, and perhaps through a smile, through a touch, a kindly opinion, whenever possible, whenever allowed, to bring transformation into the lives of others. Guide these doctors who are doing an amazing job, and all of those who are following them, so that this work doesn't stop here. May your presence be with us as you have given us a beautiful example of love as our Master Jesus. Wishing each one of us the best until we see ourselves again 2 years from now in the next meeting of the Spiritist Medical Association. We thank you, and so be it. Before we part, we would like to remind everyone, stay put, don't go anywhere. First of all, we would like to invite the speakers, the doctors, to come to the stage so we can take a picture. Then we will take a second picture with all the workers, the collaborators of the event. And then guess what? Everybody together. How about that?